Hello and welcome to Virginia Medical Updates. As we discussed in the previous session, the cholesterol and the issues that have to do with treatment or not treatment of cholesterol have been a major source of debate in the medical community for the past 3 decades. In general, as we discussed in the last session, the most important and the easiest to comprehend determinant of what the risk is in terms of cholesterol is not the total cholesterol. Rather, it is a ratio of the total cholesterol to HDL, or the total cholesterol to the so-called good cholesterol. So if we have a person that has a total cholesterol of 200 and patient 1 has an HDL of 50, and patient number 2 has an HDL of 20, correct? Patient number 1 will have a risk factor of total to 50, which basically is going to be 4. Patient number 2 is going to have a risk factor of total to 20, which is going to be 10. This person is a very high risk of developing heart disease. This person is below average risk of heart disease, even though the total cholesterol in both cases is the same. But other ways to increase HDL includes weight loss and exercise. And exercise does, in a very modest way, but it does increase HDL and decrease the chance of heart disease. Moreover, if you have someone that has a history of smoking or is an active smoker and they quit smoking, then the HDL also will go up. So number 1, exercise, and number 2, quitting smoking. The third issue is the third possibility, the third way of increasing HDL is nicotinic acid or niacin, which has been used significantly in medicine. It turns out that in general, those elevated numbers through niacin do not translate to decrease in mortality and morbidity. So when you treat people with niacin and their HDL level begins to go up a little bit, that artificially enhanced HDL does not mean that there is a decreased risk in heart disease. That's the most important thing. So exercise and tobacco cessation are the 2 ways to increase HDL, and that's the ways we have right now. However, so far, as you know, in medicine, we've always treated to goal. So we have, for a long time, and this is a criticism of the establishment, really, in a sense, that we have always treated to goal. Like we say, for example, treat the goal of 100, or the goal of 130, or to the LDL goal of, for example, 70, But it turns out that the treatment to goal is not really the best way to go about this. And in the past few years, studies have been done. And the studies have been showing that it is not really a targeted goal that actually is beneficial. But what is actually beneficial is the use of statins in general. And statins are a class of medications that actually build a block in the pathway of the cholesterol synthesis, and they decrease the amount of cholesterol that a body can naturally make. And these drugs have been modestly beneficial and have been useful. They do block the synthesis of cholesterol molecules in the liver, and that is a very beneficial thing. However, the most important thing here is that if you have a cholesterol level that is elevated, to treat to a goal is actually not the right thing to do. And in the past few years, there has been a new knowledge that has debunked some of the old ways of thinking in cholesterol treatment. So we used to treat to goal, like we would say, treat a diabetic, for example, to an HDL, to LDL of below 100, correct? Or to an LDL of 70. But this mode of treating to goal is actually now not thought to be the best way. The best way now is this. We begin to treat people that fall into 4 categories. And I always ask my medical students this question: what 4 types of people do we treat with statins? And the answer is there are 4 groups. Number 1, people with LDLs of above 190. Number 2, diabetics, Number 3, people that have coronary artery disease or evidence of bypass in the past, or evidence of disease in the arteries. So people that have heart attacks, for example, people that have stents, that population. And then the 4th group, which is the most maybe controversial, is the people that have a 10-year risk equal to 7.5% or more of actually having a heart event in the next 10 years. So if your risk is thought to be, by some metrics, to be 7.5% in the next 10 years, then that population gets statins also. So I think the LDL issue is important. If the LDL is 190, the idea is that irrespective of HDL, you could treat that. The evidence there is modest, but it is useful. Diabetics, I think I agree, that's a very useful population to treat. The people that we need to treat for secondary prevention, the 3rd category of people that have had heart disease, stents, bypass, absolutely. That's a kind of no-brainer. The 4th group, there is some debate within the cardiological circles, and they do seem to suggest that that 7.5% over 10 years is actually a low number, meaning that we should let that go up to 10%. So if the risk is up to 10%, potentially that could be treated. But if it's only 7.5%, that's debatable. So there is a debate there within the community. However, the official position right now is that at 7.5% 10-year risk, we treat. This is important because you don't want to also be using these medications, these statins, too much. They cause myalgia, muscle ache, they cause liver issues. Some of the more generic forms are really painful to the body. I've had people that can't use their hands really well, back pain from the medications. And so basically, in those people, you have to actually stop the medication to begin with. Something that I'll end with for this session that is very useful is also the use of Metamucil. Metamucil by itself, Metamucil is used for constipation, for kind of softening the bowel, that kind of stuff. Basically, the powder form drops the cholesterol by 15%. So if you have a patient, for example, that has a cholesterol of 300, if they go on 2 tablespoons of Metamucil before meals, that actually drops cholesterol by 15%, which basically means for that person it will drop 45 points, and the number will drop to 255. You can see that this is a pretty significant drop using just Metamucil by itself. And it's because Metamucil is basically a fiber product, it binds the cholesterol, and it basically doesn't allow the bile to be reabsorbed. And it's a fantastic, easy, cheap, and harmless way of treating cholesterol for some patients. So in general, yes, we do treat cholesterol. Yes, it's important to treat cholesterol. Yes, the studies have shown that treatment of cholesterol is very beneficial. The current thinking is that we use high-dose statins or moderate-dose statins, but in my experience, the low-dose statins, the mild statins also work pretty well in terms of reducing the overall burden of disease. However, the four groups that we treat are people with high LDLs of 190 or above, diabetics, people with heart disease, and people that have a 7.5% risk of heart disease in the next 10 years. If you have any questions or concerns or want to run some ideas by us, we'll be happy to hear from you at Virginia Medical Updates. Please feel free to contact us either on social media or by email.